Welcome everyone. I'm Hiba Budaya, the Educational and Patient Program Manager for the ERN-EuroBloodNet. So it's the European Reference Network on Rare Hematological Diseases. I'm pleased to welcome you all, not only on the behalf of the ERN, but also on the behalf of the European Haemophilia Consortium, EHC, because indeed this program titled Topic on Focus, Aging Well with Rare Bleeding Disorders for Patients and Families has been co-organized by the ERN and the EHC that is represented by our EPAG Mario Stanasi. So this educational program, consisting of 4 webinars, form part of the broader educational program, which is the Aging Project, Living Well, Aging Well, launched by the EHC on the 1st of October 2025. And for explaining that, I will pass the floor to my colleague Daria Camilli from the EHC, so she can explain to us the pedagogical objective and all the idea of this project.
Thank you, Hiba. So as Hiba said, my name is Daria Camilli. I'm Education and Communication Manager at the European Haemophilia Consortium, or EHC. But before I tell you a bit more about the program and today's webinar, I want to tell a few words about the EHC. So EHC is an international non-profit organization representing 49 national patients organizations for people with rare bleeding disorders from member states of the European Union and most member states of the Council of Europe. We represent approximately 120,000 people diagnosed with the rare bleeding conditions, such as hemophilia, von Willebrand disease, and other extremely rare bleeding disorders across Europe. As Hiba said, indeed, we launched on World Geriatric Day on the 1st of October 2025, a one-year-long project on aging, living well, aging well. And our aim is to explore how to support healthy, active, and fulfilling lives at every stage of aging for people living with a bleeding disorder. It is offered in 3 complementary formats: webinars, virtual cafe talks, and peer pioneer podcasts. So the webinars, we do them together with the ERN-EuroBloodNet, and this is today we have the first one. They address the challenges of aging with bleeding disorders through expert-led sessions. Topics include redefining frailty, understanding how aging affects bleeding, and managing cardiovascular and other comorbidities. The series brings together clinicians, researchers, and patient advocates to foster research across Europe and discussion. So the session will be recorded, today's session and the whole series, and will be part of the ERN-EuroBloodNet website and educational YouTube channel, as well as the EHC channels and also Academy. And to tell you a bit more about the housekeeping rules, I give the floor back to Hiba.
So before arriving to today's lecture, I want to share with you some housekeeping rules. As Daria mentioned, this program is recorded, so if you don't feel comfortable with that, you can switch off your camera. And also your microphones are currently muted, but at the end of the presentation, you will have the possibility to raise your hand if you want and ask any question, or you can drop your question in the chat at any time during the presentation, which will be answered afterwards during the Q&A session. Also, if you don't feel comfortable asking the question in the chat, you can send it privately to me or to my colleague Daria, and we can raise it anonymously. One more thing that I want to mention with you before we start, we have a new AI tool for translated captions. If you wish to use it, please follow the screen capture here. You have this icon with double C. You can click on it and you select the translation of the language people are speaking. So now we are speaking in English, you select English, and then the language you wish to have the captions with. So I'm honored to present our speaker, Professor Susie Shapiro, who is a consultant hematologist and associate professor at Oxford University.
And it's my great pleasure to introduce to you Dr. William McKeown, EHC Steering Committee member, consultant geriatrician and stroke physician, lead for undergraduate aging and health at Queen's University, Belfast, UK, and advocate for healthy aging. So when we talk about frailty, I want to say that we all experience aging differently. And for people with bleeding disorders, it can bring specific concerns and challenges. But aging with a bleeding disorder does not mean losing strength or independence. So today we are going to have a powerful conversation with our speakers about healthy aging and resilience. William, the floor is yours.
Well, thank you both very much for the warm introductions. As has already been said, I am a geriatrician, a physician who specializes in older people's medicine, but I'm also a patient with severe haemophilia A. So today's topic is very, very close to my heart. So redefining frailty together, living better for longer. I think the focus can often be very negative in aging. It's all about losing things. It's about loss of independence. Actually, we want to reframe that as maintaining independence, maintaining self, even if you have a rare bleeding disorder. Just a few disclosures to make before we start. So I have three things that I want to tell everyone about today. First is talking about what frailty is, and this is a very important concept in older people's medicine. I want to talk about frailty syndromes. So these are often the manifestation of frailty that patients encounter. But what I want to spend most of my time on is actually framing this positively and talk about the manifold solutions that we have and things that we can do to ensure people age successfully, that their frailty syndromes do not progress, that their frailty does not progress. So what do we mean by frailty? Frailty is a really important concept in older people's medicine, and I have quite a wordy definition here. So a state of increased vulnerability due to accumulation of deficits, which leads to a poor resolution of homeostasis after a stressor event. I don't like that definition. That definition was written for doctors, and what we need is a definition that people can actually use. So for me, it's loss of physical resilience. So you become less physically resilient because of health problems that you encounter. What do I actually mean by that? Well, I often use this graph on the right to help people conceptualize what's meant by frailty. So people who don't have frailty, they are the green line. So they have a very high level of functional ability. They're independent. They can look after their own house. They can they feed themselves, cook, drive. They can manage things themselves. But they might get sick. So, for example, this week I had a cold. So I wasn't quite as independent for a while. I couldn't go for a run. I wasn't feeling very well. So my function dropped a little bit, but I bounced back to normal quite quickly. So that's what life is like for people who don't have frailty. But then we have the red line. So people who have frailty, these people are the red line. So they have a lower level of functional ability. So they might be able to look after themselves, but it's a struggle, or perhaps they might need a little bit of help to take care of themselves. They lack physical resilience. So when the stressor event comes along, say an infection or a new medication, they have a big drop in their function. Suddenly they can't look after themselves. They can't walk. They can't get up their stairs. They have a big drop in function, and it takes them a long, long, long time to recover. And actually, they don't have physical resilience, so they may not be able to fully recover. So that's what frailty looks like for me. So it's a lack of physical resilience. That means when stressor events and health problems come, it's more difficult to bounce back. Why are we talking about this in an ERN webinar? That's a great question. Well, there are two reasons. So number one, frailty is associated with age. So as people get older, they are more likely to have frailty. Now, I don't want to be misunderstood. That does not mean all people get frailty as they get older. That's a misnomer. But we do know that people are more likely to have frailty than when they get older. Now, that has to be paired with some of the changes we've seen in the demographics within our community over recent decades. So because our treatment has improved so much, in many cases, particularly haemophilia, we've seen life expectancy go up significantly. So it's very simple. We have a condition that's more common with age. and we have a population which is getting older. So it is therefore inevitable that we will have more people with bleeding disorders and frailty in the years to come. So that is why we're here talking about this today. So this is a way we measure frailty. So if you're over 65 and you want to know if you have frailty and how significant that frailty is, the way we often assess that is through something called the clinical frailty scale. And this really measures somebody's physical resilience on a 1 to 9 scale. So if you're a 1 on the clinical frailty scale, you don't have frailty. You're very resilient. You'll cope with stressor events and ill health. But if you have, say, if you're a 7 or an 8 or a 9, you have severe or very severe frailty, you're somebody who may not be physically resilient. And this scale is predicated on the premise that somebody's ability to function predicts how physically resilient they are. I should say this is a tool that is well validated. It's a Canadian tool, but it's used globally. We don't actually have any specific tools to measure frailty in haemophilia. So I think for now, or indeed any other bleeding disorder, so I think for now, we are really trying to learn how to use existing tools for our population. And I know Susie's going to talk a little bit about that later. So the consequence of frailty is what we call frailty syndromes, and that's what I'm going to spend most of the rest of my time talking about. And if anyone's interested in doing some reading, myself and Susie have a paper on this, which you can read online. It's freely accessible. So these are what we call the geriatric giants. So we know that people who get older and who have frailty, they often have some of these 5 problems. They may have all of them, and you can remember them all easily because they all begin with the letter I, at least in English. So what are the geriatric giants? So immobility. So we know people as they get older, as they have frailty, they often walk slower. They can't get around their houses quickly. It takes them longer to walk into town. We know they have instability. So they're not as stable. Their balance might be compromised. They may be more likely to have a fall. We know that people who have frailty are more likely to have incontinence, so they don't have control over when they go to the toilet. Our next I is impaired cognition, i.e. they have a memory problem, and this can manifest as dementia, so we're familiar with that, which is a chronic problem with memory, but it can also manifest as an acute problem, what we call delirium. So perhaps, I'm sure a lot of people here have had an older relative, they'll have noticed when they get sick, sometimes they become confused. That's delirium. And then the final is iatrogenesis. This just basically means that if you have frailty, you're vulnerable to side effects. So whereas, for example, a medication for pain relief like morphine or codeine might be well tolerated in a younger person, in a person with frailty, it can affect them very severely, and they may be more likely to get the side effect than the benefit. So these are our 5 geriatric giants, and these are the real life consequences of frailty that patients face. But there's good news. So and that it is twofold. So number 1, a holistic multidisciplinary assessment, we would term that a comprehensive geriatric assessment, keeps older people alive and it keeps them in their own homes. So if we intervene on frailty in a holistic, in a multidisciplinary way, we can significantly improve people's outcomes. And we've known, certainly within the bleeding disorder sphere, for a very long time that multidisciplinary care provides better outcomes. It's definitely true for older people with frailty. The second piece of good news is that often the drivers of frailty and the frailty syndromes I mentioned, they're multifactorial. There are lots of causes. And that might sound bad, but actually it means there's lots of opportunities to make things better. So how do we address these geriatric giants, these frailty syndromes, immobility, instability, iatrogenesis, impaired cognition? Well, let's talk a little bit about that. I'm going to talk briefly about immobility and falls, but just to mention that we will be having a more detailed webinar on this in due course. But we do know that as people get older, they fall more often. About 40% of people over the age of 85 will have a fall in a year. And there are lots of things that put you at risk of having a fall. So if you have bad joints, if you've lost muscle, if you're pain, if you have depression, they're all listed here. But I've highlighted a couple of these because I think they're under-recognized. So the first one is postural hypotension. So when you're young, your body's great at regulating your blood pressure. If you stand up, you sit down, your blood pressure is very steady. As you get older, your body's ability to manage blood pressure, it becomes diminished. And so your blood pressure might become very variable, very up and down. And what we often see is as people change their posture, so going from lying to standing, for example, their blood pressure might drop. And we know for people who have drops in their blood pressure, they're much more likely to fall. And we would define that as a drop of more than 20, and the top number, that's your systolic blood pressure. The other thing is the environment. And so this is often the sort of house I go into when I'm out in the community. And you can see it is just a disaster. So an older person, they might have their walking aid on the floor. They've clothes everywhere. They maybe don't use their walking aid. Their tablets are on the floor. The room isn't very well lit. So the environment, how your house and your home is set up, is massively a contributing factor to falls. And so not what we're saying is not, you need to have a totally sterile environment in your house, but what are the things in your house that could be obstacles or hazards? So maybe it is have well lit rooms. Maybe it is remove the rug or the carpet that you could trip over. Maybe it is have things stored away, because actually our home environment, people are more likely to fall in their own home than anywhere else. It's really important, and those are two things that I would highlight for immobility and falls. So, as I've said, you saw there were lots of driving factors for falls, and therefore we need to think about lots of different solutions. So all the different things that contribute towards reducing falls risk. Again, I've listed different things the multidisciplinary team might do, medical, nursing, physio. But there's a few I wanted to highlight. So number one, screening for osteoporosis. So we know in people with hemophilia, there is a much higher rate of osteoporosis. And by osteoporosis, I mean brittle bones. So the one thing that can make a fall 1,000 times worse is if you break a bone. And we know people with hemophilia have a much higher incidence of osteoporosis. So anyone with a severe bleeding disorder and a fall should be screened for osteoporosis, because actually there are things we can do to make people's bones stronger. Weight-bearing exercise, vitamin D, calcium, other more heavy-duty tablets called bisphosphonates or denosumab. So there's lots we can do for that. I've put here lying, standing, and blood pressure, so checking for those irregular blood pressures. And I've also put environmental assessment. And the good news is this: if we do a holistic intervention for people who have falls, we can significantly reduce their falls risks by about a third. And just remember, it just takes one fall to have a really bad outcome. So if we are stopping 33% of falls, then that's a really good outcome for patients. So take-home message on falls is always ask, why did it happen? Because if you don't know why it happened, you can't start fixing the contributing factors. So next I want to talk about incontinence. And I have to be honest, I think we are really bad at talking about incontinence. We're embarrassed about it. And that's a real barrier. But we know it's very, very common. So in the community, about 10% of people have issues with urinary incontinence. 5% will have issues with fecal incontinence. For people who have advanced frailty, for example, those in residential and nursing homes, rates are very, very, very high. And it may be for older people trying to go to the toilet, it is like climbing a mountain. And so we need to think about what we can do for this. There are lots of things that increase your risk, particularly for incontinence, and I put those here. But immobility and lifestyle were things that I wanted to highlight. I think one thing I also wanted to highlight was just how impactful this can be in people's lives. If you don't have control over when you go to the toilet, you might not leave your house, or you might not go to certain places, or for example, I see with older men, they just try not to drink any water. So they come in very dehydrated, very dizzy, kidney failure. It's a real problem. So we really do need to take this seriously and ask about it. A really shocking statistic I came across in preparing for this talk was that 78% of men who have weekly incontinence do not seek medical help. So I think men in particular do not want to talk about this, and they are just suffering in silence, and it's affecting their lives. They can't go out, they're not drinking, it's really bad. It's a real shame they don't seek help, because like everything that we're talking about today, there are lots and lots of things we can do to give people more control over their bowels, give more control over their bladder. So there may be things that I am prescribing, like diuretics or water tablets. There may be issues, for example, prostate issues that I, as a doctor, can intervene on. Certainly, nursing can be a real critical support for people with incontinence, and often the best solution is not tablets, but things that people can do themselves. So we know high alcohol content, high caffeine content, high fluid content late in the day. These can all contribute towards incontinence. I think our physiotherapists are key though. So certainly they can pelvic floor exercises strengthen the muscles in the pelvis, which can give you control back. And you can actually adapt your home to make the toilet more manageable. So it can be very hot. If you have poor muscle in your legs because of frailty, getting on and off a toilet can be really difficult. And you might think, maybe I'll just wait a bit longer. Actually, simply by putting a different toilet seat on so the toilet is higher, by putting grab rails up, you can make the toilet so much more accessible. Suddenly you can go to the toilet and not have to be incontinent or avoid going to the toilet. So there's really so much we can do when it comes to incontinence. But if I had one single take-home message on incontinence, it would be simply this. Please, please, please tell your doctor about it. And if you are a healthcare professional, ask about it, because it's super under-recognized. The next geriatric giant was cognitive impairment or impaired cognition. And I think this is one of the most difficult ones to deal with. Often when sometimes I put up questions when I'm giving talks, what do you fear most? And dementia is usually near the top, losing your memory. I think dementia is hard because actually you're losing yourself, aren't you? So the picture here, this is quite sad, but this is a picture drawn by an artist called William Udermohlen, who's an American artist, and he did a self-portrait the day he was diagnosed with dementia, which you see on the left. And then he kept doing self-portraits every month until he died, and his final self-portrait is on the right. So, I think this is a really powerful visual reminder of how dementia can rob somebody of themselves. So what can we do about this? Well, there are lots of things that put people at risk of dementia: depression, high blood pressure, intracranial bleeding, which we know is more common in bleeding disorders, even milder bleeding disorders, and also poor hearing. And there are obviously lots of adverse effects of loss of memory, which we've talked about here, and certainly it can create real strains within families. So what can we do to not just manage cognitive impairment or memory problems, but what can we do to prevent them ever happening? Well, I think first of all, we need to be assessing for it, and we need to be looking at medication that can contribute to memory impairment. So I see a lot of patients come in whose tablets are significantly impairing their memory. They're on too many sleeping tablets, too much pain relief that's not giving them pain relief, but it's giving them side effects. So there are a lot of medications that can make this worse. Certainly, nursing staff are excellent at helping families prepare for and cope with dementia. So what do you do with your loved one when they're agitated or disorientated? How do you reorientate them? How can you make the house more friendly and dementia friendly? One of the big things I think we need to talk about though is hearing. So hearing and poor hearing is the single biggest preventable cause of dementia. So if if nobody had any hearing problems, about 8% of dementia wouldn't be there. It's the single biggest thing that we can intervene on to prevent dementia. So I would say to anyone, especially in midlife and later life, if you have bad hearing, get your hearing checked. That's the single biggest thing you can do to keep your brain healthy. So the take-home message on cognitive impairment, well, it might surprise you, but never ignore a hearing problem. Get your ears checked. So our final geriatric giant is iatrogenesis, which we could also describe as side effects of medication and polypharmacy. By polypharmacy, we mean taking lots of medications. There's a lovely French study done a few years ago called the Emerge study, and it found that of older people with both haemophilia and von Willebrand's, almost 60% of them were people who had polypharmacy, so they were on more than 4 medications. And the key risk factors were chronic pain. We know people with bleeding disorders often live in chronic pain, and multimorbidity. And again, we do know that a lot of health problems occur in people with bleeding disorders, like high blood pressure, at a higher rate. This is really significant because all tablets have side effects. In fact, a lot of tablets have multiple side effects. So if you're on lots of tablets and you have frailty and you're vulnerable to side effects, very, very quickly you can run into problems. And the picture on the right demonstrates what I fear healthcare systems in the West do to older people. So we come in, we want to help, we have lots of good intentions. So we arrange lots of tests, lots of hospital appointments, we prescribe lots of medication. And actually, it can very quickly become a burden. So we need to really prioritize for older people what medications are most important. Now, it may be totally appropriate that somebody is on 5 or 6 tablets, but we know very often at least one of those could be stopped or changed. So we have polypharmacy, that's 4 or 5 medications, depending on the definition you use. We actually have something called super polypharmacy, people who are on more than 10 medications, and this is much more common than you would think. And it's associated with lots of very negative outcomes. So people who have super polypharmacy, they're taking more than 10 medications. Their mortality risk, their risk of death is doubled. Their falls risk is tripled. So this actually is a really bad thing. So what can we do about this? Well, I think the biggest thing we can do is keep reviewing our medication. And if you're a patient on lots of medications, just do check in with your healthcare professional now and again. Why am I on this? Is this still good for me? These are good questions to ask. Often what I see is that medications are started and they might be very, very appropriate, but 5, 10, 15 years pass. Nobody has ever reviewed if that medication is still good. And actually people's bodies change. We get older, we get frailty, and those tablets might not be right for us anymore. So we need to keep reviewing our medication, keep asking questions of our healthcare professionals. Are these the right tablets? And we need to consider maybe we don't need a tablet for this at all. If you're taking pain relief that doesn't relieve your pain, for example, maybe you shouldn't be taking it. And here I've put anticholinergic burdens. We prescribe a lot of anticholinergic medication. Acetylcholine is a neurotransmitter that's critical in the brain, and actually a lot of our common medications inhibit that. So common tablets that affect that will be certain anti-sickness tablets, tablets for overactive bladder, certain tablets for nerve pain or antidepressants. So certainly these are tablets that I often think about stopping or changing or reducing. And here's how I calculate it. I calculated using this useful online tool. And if you're interested to know if you're someone who's on lots of tablets, you want to know if you're taking these anticholinergic tablets, you can check it yourself on Google. And so what is the key message on medication? Well, it's review your medications. Keep checking the medications are right for you. Don't just assume that a prescription is for life, because that is not true. People change, their bodies change, and these things need kept under review. So that's a very whistle-stop tour of what I do every day. That's what I think frailty is. That's what frailty syndromes are, and that is how we address them. And the good news really is that there is so much that can be done for frailty, whether you have a bleeding disorder or not. So please think of frailty syndromes, and yeah, I'd be more than happy to answer any questions that you might have. Thank you.
Thank you, William. We will address the questions after the presentation of Susie Shapiro. We will have the Q&A session. Just to remind you that you can drop your questions in the chat. And if you don't feel comfortable asking them out loud, you can actually also raise your hand and ask out loud. But if you don't feel comfortable doing that, send a message to Hiba or to me, and we will ask them anonymously.
Thank you. Okay, I'm going to try and share my slides from beginning.
It works well.
Great, perfect, thank you. So hi everyone, I'm Susie Shapiro. I'm a haematologist based in Oxford in the UK. And it's a pleasure to be doing this talk with Will today. So I guess many talks that we do for bleeding disorders, we really focus on the bleeding disorder and how we know something specific affects it. And the reason that we've maybe done this a little bit differently with Will doing a general talk on frailty is actually this is a really new area for us within bleeding disorders. I think that everything Will has just spoken about will apply to people with bleeding disorders. The question for us now is, does it all apply? Do we need to be doing more? And so in my talk, I'm going to focus on haemophilia and bleeding disorders and what we know about frailty and frailty syndromes at the moment, and how much more we need to understand in the future. And then we'll come back to what we can do going forwards. So these are my disclosures. So I guess the reason we are limited in what we know about frailty and frailty syndromes in bleeding disorders at the moment is twofold. It's partly because historically haemophilia care has focused on those with the most severe bleeding disorders. And it's only relatively recently where we've had safe and effective treatments that we see an aging population of people with bleeding disorders, particularly those with the severest bleeding disorders. And so then as doctors and healthcare professionals, we have started to see more comorbidities of aging in this group of patients and have started to try and think more about how to manage age-associated comorbidities in someone with haemophilia, whether they're specific or not. And the way that we've done that historically is with what we call a classic systems approach. And by that, I mean, we think about the heart. What's someone's heart vessels like? Have they had a heart attack or a stroke? We think about their lungs. Do they have breathlessness? Do they have chronic lung disease? We think about their guts. And so these are not specific to haemophilia, but they are associated with aging. And then in someone with haemophilia or another bleeding disorder, we may need to treat it a little bit differently, or certainly give them extra support and liaison with the specialty. We think about the brain, including dementia, and also bone health. And that's how we've classically kind of done it in writing papers and seeing people in clinic. And so on that note, about 7 years ago now, I wrote a paper with one of my colleagues about the clinical management of people with haemophilia and I think other bleeding disorders in older age using this approach. So in all people with bleeding disorders, we're thinking about preventing and treating bleeds, in particular joint bleeds, traumatic bleeds, intracranial hemorrhage. We want good blood pressure control, gastrointestinal bleeding, particularly people in von Willebrand's disease where there are abnormal blood vessels can form, which is called angiodysplasia, and the risk of that increases with age. And also in everyone, whether or not they've got a bleeding disorder, people often notice easier bruising because of skin fragility with age. We also need to think about an accumulation of joint damage over time, so chronic joint damage, pain, and functional restrictions because of that. And for those who received infected blood products, HIV and hepatitis C. But for in addition, there are other things that we need to that the haemophilia team should be actively thinking about and engage with to support other issues alongside the bleeding disorder as someone ages. And indeed, it may be that some of these other issues potentially become the most important overriding aspect of someone's care over time. So we need to think about the bones and the muscle health. Will's already said that certainly people with haemophilia have an increased risk of osteoarthritis. I'm not sure that it's there with the other bleeding disorders, but it's particularly there with people with significant joint disease. Osteoarthritis and osteoporosis, sorry, with significant joint disease, with mobility, balance, and increasing tendency to falls. We need to be thinking about the risk of heart disease and stroke because it is no longer thought that people with bleeding disorders are significantly protected from heart disease and stroke, but we are still needing to learn more about that. Cancer, decreasing visual acuity, and how potentially that affects someone's treatment for their bleeding disorder, depression, loss of social network, cognitive impairment with dementia, and loss of independence. And so that's kind of how we've been thinking about growing older with a bleeding disorder through the systems approach. And it was shortly after I wrote this paper that I was at a meeting with Will, and he said, well, Susie, I really like that paper, but you can tell neither one of you was a geriatrician because that's not how we think about aging. We now think about aging in a global way in frailty and frailty syndromes. And so Will educated me on this, for which I'm very grateful. And really kind of what we've done since then is a joint effort to try and understand this phenomenon more in people with bleeding disorders. There is very limited data on frailty and frailty syndromes in people with bleeding disorders, and it's the bulk of it is probably since we can extrapolate from other things, but it's really what we've been trying to work on over the last 4 or 5 years. Almost all the studies have been conducted in male patients with haemophilia. So I apologize now to everyone who doesn't have haemophilia and is not male. I'm going to mainly talk about male people with haemophilia now because that's the only place the evidence is for now, but I will try and pull out what may or may not affect other people with bleeding disorders. The essence is that Will and I suspect that that frailty and frailty syndromes in general will apply across the board to people with bleeding disorders because it is a global disorder rather than something specific. So after this initial conversation with Will, we thought locally that we would go back and review the medical records of our patients to see if we could work out whether they were frail or not, because it wasn't a routine assessment that we did in clinic. So I work at a large haemophilia centre in the UK, and when we decided to look through the medical records of people over the age of 50. And the results that I'm going to show you next are divided in those between the ages of 50 and 64 years old and those over the age of 65. And the reason we're doing it like that is because, as Will alluded to earlier, the clinical frailty scale, which is the validated, simplified way of measuring frailty, is mainly validated in people over the age of 65. But so we did that with that cutoff because that's good for comparing to other groups, but we also wanted to look in a slightly younger cohort as well. So what we know that has been published for the UK population, that in general, 10% of the UK population over the age of 65 have a degree of frailty. So when we looked back in the medical records of 87 patients where we thought we had sufficient detail to try and calculate a frailty score, 29% of our patients with haemophilia we considered frail or had evidence of frailty. And for those between the age of 50 and 65 years old, 17%. So it looked, by looking back through the medical records, that there were high rates of frailty in people with haemophilia, higher than one would expect for the general population and starting at an earlier age. But, you know, us looking backwards through the medical records, it is quite limited. But what it did was give us enough of an impetus to say, actually, going forwards, we're going to start measuring frailty using the clinical frailty score at our routine outpatient clinics in all people with haemophilia more than 50 years old or older. And we worked with our local geriatricians to establish new guidance for people with haemophilia and for referring them if frailty was identified. There is always a lack of, well, there's certainly a lack of resources in the NHS at the moment. So the pathway that we were given is that if someone has a clinical frailty score of 4 or more, which is the first degree of recognizing very mild frailty, we would just highlight it to the GP, to the primary care practitioner, but that we could refer to our hospital geriatrics clinic if the clinical frailty scale was 6 or more, which indicates moderate frailty, or if there was a new frailty syndrome. So that was what we planned to do. We have 116 people registered over the age of 50 years. And for the last couple of years, we've aimed to measure the frailty score in outpatient clinic routinely. So over that time, we've almost got all 116. So we've got results for 111 patients. So we're just preparing this for publication at the moment. So you guys get a bit of a preview of these results. So the age range was 50 years to 88 years, and the average age was 62 years. And this graph shows the number of patients on the y-axis. It's got 2 age ranges. So on the left-hand side, it's the 50 to 64-year group. And on the right-hand side, it's everyone over the age of 64. And then we looked to see what severity of haemophilia people had. So whether it was mild, moderate, or severe. So what you can see, which is what you'll see at kind of all haemophilia treatment centres really, is that in the older age category, those over the 65 is still currently skewed to people with mild haemophilia, and there are much fewer people with severe haemophilia than in the younger age categories. That is changing all of the time. But so in our older population, there are far fewer people with severe haemophilia than in the younger population, and you'll see how that kind of changes the data a little bit. So the next couple of graphs I'm going to show you are the clinical frailty score dependent on the age and the haemophilia severity. So this graph is for the younger age group. So the mild haemophilia is in pale blue, people with moderate in medium blue, and people with severe haemophilia in black. And the cutoff for the clinical frailty score of having frailty is 4 or more. So you can see on this right-hand side that 18% of our population between the age of 50 and 64 years had frailty when we properly measured it. It was actually very similar to what we had kind of estimated from the medical records, but measuring it properly, 18% for the younger age group. So just to remind you, 10% of the general population over the age of 65 have frailty. So this is high. The other thing to note is that all of the patients in the younger group who were frail had severe or moderate haemophilia. Okay, so it starts to make one think, well, maybe there's something about underlying joint arthropathy that is causing the increased frailty at a younger age. So I've just moved that graph over to the left, and then this is the graph for patients over the age of 65. So 33% of people over the age of 65 were frail. And what you can see is actually, if we look at the right-hand side for those who were frail, partly it went up to really quite severe frailty, but there was much more of a mix of mild, moderate, and severe haemophilia in the older age group who had frailty. this is a very busy graph, but we did look at the frequency of other medical comorbidities in anyone with frailty. And there's a whole range of things from high blood pressure to heart disease to stroke to HIV and hepatitis C, diabetes, cancer, etc. So what did we actually do? What is the impact of us measuring it? So we should, everyone at our centre, certainly with severe and moderate haemophilia, should have a routine physiotherapy review anyway. And so certainly the majority of patients got that, but we would also offer it to anyone who had joint or mobility issues of any severity or any bleeding disorder, any severity of haemophilia or any bleeding disorder. In the main, we notified the GP that they were slightly frail, as per the guidance that we were given. Some were already under community teams. Some already had geriatrics input. We didn't make any new referrals to the Falls team, but I guess we've got a very good physiotherapist locally who was used to working with people with haemophilia. And there's a couple that I need to go back to that no action was taken, so I need to explore that a bit further. And then this so frailty, CFS of 4 or more, but a CSF of 5 or more is mild to moderate frailty. And so what I wanted to do was just to look at the people who were the most frail to see what was driving that in our patients with haemophilia. And there were only 8 people here. So just to take you through, on the left-hand side, the top 3 all had severe haemophilia between the age of 54 and 68. Here, the HJHS is the haemophilia joint score, which ideally is 0. And all of these numbers of 33 to 57 indicate that someone has very significant haemophilic arthropathy. We looked to see if people had 5 or more comorbidities, and only one of those patients with severe haemophilia had 5 or more comorbidities. But all 3 of them had significant haemophilic arthropathy, and some also had other types of arthropathy from other types of illnesses. We had a couple of people with moderate haemophilia, and they had significant haemophilic arthropathy. Whereas the people with mild haemophilia at the bottom were slightly older, between the age of 71 and 88 years. They all had 5 or more comorbidities, so other medical conditions. And actually the driving factor wasn't haemophilic arthropathy, it was other things. So one had ankylosing spondylitis, which is a type of autoimmune arthritis, and had also had a total hip replacement. One had significant heart disease and arterial disease in the legs, and one had had a stroke. So I guess it looks as though for those with severe and moderate haemophilia, haemophilic arthropathy is a key driver of frailty. But as everyone gets older, and particularly those with mild haemophilia, the frailty drivers are likely to be similar to those of the general population. And the impact, what impact did it have us looking at the frailty in Haemophilia Centre? The main thing was to ensure our physiotherapy was involved with orthopedics, and that we highlighted it to the GP in primary care. And the ones who really needed kind of mobility aids or a social care package actually already had it underway without us, but potentially in the future we could help pick that up. So that is what we know really so far about frailty in people with haemophilia. And I guess a key thing, the reason that we wanted to start identifying it is we know from everything that Will presented that if frailty is identified, then people can have multidisciplinary holistic interventions, and frailty can be reduced and you can have a better outcome. So that's really why we want to start looking at it in haemophilia. Does a clinical frailty score 5 mean the same in someone with severe haemophilia as some without? We don't know for sure. We suspect it does, but we don't yet know for sure. But surely if we should be helping identify it and getting people into the right pathways. So just a little bit on the frailty syndromes that Will talked about. I say a little bit because we know even less about frailty syndromes in people with bleeding disorders and haemophilia than we do for frailty in general. So this table lists the 4 main frailty syndromes. I've kind of ended up doing falls and immobility together because there's not good data for immobility in people with haemophilia. So for the general population, the falls risk is thought to be about 9% in people who are aged 55 to 64 years old, and about 24% in those over the age of 75. What do we know about people with haemophilia? Very, very little. There are 2 studies looking at much younger patients in haemophilia, so with an average age of 40, and they found a falls risk of 30%. So it suggests in haemophilia that the risk of falling occurs at a much earlier age. When those papers looked at the cause of fall, it was often linked to, it was generally linked to mechanical reasons, so lack of balance or tripping over something, but kind of very mechanical. And so certainly locally, our physio works a lot on balance and confidence going up and down stairs, side to side, regaining balance. If one has a bit of a trip, to try and stop the fall. So again, I think as Will alluded to, there's a separate session about falls that will go into things like that in more detail. But falls are important to prevent for all sorts of reasons, particularly in people with haemophilia, because if you fall and you have a bleeding disorder, haemophilia or another bleeding disorder, you're at higher risk of bleeding, of traumatic injury, of a big bruise. Also, if you have osteoporosis, you're at higher risk of having a fracture. So if we can avoid the fall, then that is much better. So incontinence, urinary incontinence in the general population, in the elderly general population, has been reported as high as kind of 21 to 32%. We just don't know in haemophilia. The only study we could find was a Dutch survey of about 70 patients with severe and moderate haemophilia. And then again, the average age was pretty young, or it's about 54 years, but there was incontinence of about 14%, which actually, given the age of those patients, is really high. And we don't ask about this routinely in clinic, and we clearly need to. Cognitive impairment, so about 20% of the general population who are elderly, we have absolutely no idea for people with haemophilia. Some of the risk factors for cognitive impairment, such as depression, have been recorded as being higher in people with bleeding disorders than those without. There is a little bit of data around microbleeds, so tiny bleeds in the brain, and whether they may be slightly higher in people with bleeding disorders compared to those without, but there isn't a good link to dementia. So we have no evidence that of the prevalence of dementia in people with haemophilia or other bleeding disorders. I also don't know that it will be higher, but again, it's really important that we find out. And also because the cognitive impairment associated with reduced independence, again, is super important for recognizing bleeds and for self-treatment. So we need to get better, basically. And finally, polypharmacy, 45% of the general population. There are a few studies on this in people with bleeding disorders, and it's thought to be about 58%. Probably a mixture of people having additional treatment for their bleeding disorder, and sometimes because of kind of treatments for HIV and hepatitis C as well. But we need to be careful and recheck whether all of those medications are really needed. So what did we find when we kind of with our patients locally? So we looked back for everyone who had a diagnosis of frailty, so with a frailty score of 4 or more, to look to see if they had frailty syndromes. So the majority of our patients with a degree of frailty do have polypharmacy. They were taking more than five or more medications. There were definitely a description of falls, so those would have been working with our physiotherapist. There were some who had very reduced mobility. So one with cognitive impairment, one with incontinence, and a few with no frailty syndrome. But we may well have underestimated incontinence because we didn't always ask. So I must be coming to the end, but this is going back to the original table that I showed you and just looking at frailty syndromes. So, oops. So for the polypharmacy, the 5 or more medications, when I looked at those with the most severe frailty within our group of patients, almost all of them had 5 or more medications. Only one of them had less than 5 medications. And falls was mixed. So 3 of the 8 had a history of falls, but it certainly wasn't across the board, but that's clearly higher than anyone would want. So, aging well together. I think ultimately we need to use both the systems approach and the global approach. If someone has high blood pressure or is experiencing an angina, we really need to be doing everything we can for cardiovascular heart disease prevention. But we also now need to not only do the systems approach, but I believe need to introduce the global approach so that we are looking at frailty and frailty syndromes when we know that they are so important in the general population. And so we are speaking the same language as our geriatricians when we say, oh, we're quite worried about this patient at the age of 70, 75, and I can communicate effectively using the language of the geriatricians to kind of flag up the things that I know that they want to hear about and may be particularly interested in. We need, as you have seen, quite a lot more data and research into this for everyone with bleeding disorders. We need to be thinking in general around primary prevention, so cardiovascular disease, bone health, nutrition, muscles, balance, reducing the risk of falling. And I know other seminars in this series are discussing that. We need to upskill our multidisciplinary team, including on frailty and frailty syndromes, and we need to be thinking about a dementia-friendly environment. We need to be thinking as doctors about prescribing reviews. Actually, should someone be on a liquid rather than a tablet? Can they be on subcutaneous prophylaxis rather than intravenous? Does that make a difference? And I think we need to adapt and expand our multidisciplinary team. So trying to involve more social workers or occupational therapists. And when people lose their independence, do education and support of carers with home visits and nursing home visits, which takes additional resource from our multidisciplinary team. And finally, we need to get much better at linking with other specialists, whether it's kind of the cancer doctors or the heart doctors that we've done previously, but more and more with geriatric medicine, so that we can support patients the best. Now, I think that if you had frailty, you definitely need to see Will as a doctor rather than myself. We're really good as a team at bleeding disorders. I am not the best person anymore to decide which is the right blood pressure tablet for you or which medication you can reduce. But I do think as a haemophilia team, we have a role in, when we see patients generally so regularly, in highlighting things to other healthcare professionals who can hopefully then be the right person. And if someone's otherwise worried about, actually this patient has a bleeding disorder, can I do X and Y and Z, then in supporting those discussions. And I think that if we work well together as healthcare professionals, patients, patient organizations, then actually the future should look like this. And that's it. Thank you.
Thank you so much. Before we move to the questions, Hiba, if I can probably share a bit more about the next things that we have in our program. So both William and Susie mentioned that we're going to have a discussion on falls So I want to make you aware that this discussion with Stephanie Taylor, a physiotherapist, and William McKeown will be made available on the EHC platforms on the 23rd of February. So please keep an eye on the EHC social media. And we have our next webinar within the framework of our webinar series together with the ERN-EuroBloodNet. That webinar will be dedicated to von Willebrand factor and von Willebrand disease in aging, mechanisms, evolving phenotypes, and clinical implications. This webinar will feature Flora Pevandi, a professor from Ospedale Maggiore Policlinico Milano, Italy, and Katie Verbraken from the EHC von Willebrand Disease Committee. You can either register for the whole series and you receive the links straight away, or to each webinar separately that you see on your screen.
Thank you so much, Daria. Maybe now we can go to the questions in the chat. And the first question says, I think this is for William. Is the explanation given about incontinence and memory loss specific to patients with hemophilia, or is it about aging in general? I don't understand the connection between this explanation and hemophilia.
Well, thank you, Bart, for that question. And I have to say, I like it when people challenge what I say. I think that's really good to have a proper discussion. So I think the reason we're talking about this today is because there are definitely some special considerations when it comes to incontinence, when it comes to memory for people with bleeding disorders. That means we have to talk about it specifically. So you're right, there's not great evidence that incontinence memory problems occur at a much higher rate in people with bleeding disorders, although we do know that many of the risk factors for both, so incontinence, immobility, polypharmacy, in terms of memory, intracerebral hemorrhage, depression, some of these things do occur at a higher rate in people with bleeding disorders. But despite the higher prevalence of risk factors, we don't know definitively if they occur more commonly. But it's what we do about these issues. So we know that, for example, talk about incontinence. Actually, the big driver of incontinence in people with hemophilia is immobility. We have bad joints from our hemophilia. So that requires a very specific approach. In addition to that, perhaps for men with prostate issues for whom surgery might be the first line, sometimes there can be hesitancy in the surgical community to treat people with bleeding disorders the same. And certainly I have experienced that as a patient as well. So people with bleeding disorders might end up being managed more with tablets, and that may or may not be the right approach, but it's going to become a factor in those treatment choices. And for example, if you can't empty your bladder, you might be somebody who needs a catheter, a tube to go into the bladder to relieve that. You know, we might be at a higher risk of bleeding if we're going to do that frequently. So there are special considerations for these issues, such as incontinence. In terms of memory, and Susie said it already, you need good cognition to manage a bleeding disorder, and it doesn't matter if you have severe, moderate, mild hemophilia, von Willebrand's, a rare disorder. You need good cognition. So I'm on factor replacement therapy. If I had dementia, the idea of me being able to make up my factor, put on a tourniquet, put the needle in the vein successfully, and remembering when to do that suddenly becomes very, very difficult. So suddenly my dementia and my bleeding disorder become a really bad combination. And maybe if I have pain in my leg, I don't think that could be a bleed. So I think that there are definitely special considerations for people with bleeding disorders when it comes to things like dementia, memory problems, incontinence that we need to start thinking about early if we're going to manage them well.
Thank you, William. So the next question in the chat that we have, what would you recommend to women with severe disorders to do about bone density monitoring, and at what age? Susie?
Yeah, so it's a really good question. I'm sorry that I have so little data beyond haemophilia and for women. The data for haemophilia, people with haemophilia being at increased risk of osteoporosis, is very much people with haemophilia. And it's been shown that those with the most severe types of haemophilia, severe and moderate haemophilia, are at the most increased risk. So what we think is causing the increased risk in haemophilia is the fact that those people, particularly those who are aging now, had bleeds into the joints when they were younger, when treatment was less widely available, and so spent quite a lot of time with reduced mobility and probably never got peak bone density. So to get peak bone density, you need to be active, having impact, you need to be doing weights. And so we see quite a lot of osteoporosis in people over the age of 50 with haemophilia, particularly the most severe forms, but it's possibly because it never went up as high as others normally. So I will come back to women, don't worry. But what we do locally is for people with haemophilia, whether men or women over the age of 50, we scan them locally. We do a bone density scan, and we check vitamin D. That won't be done everywhere, but that's what we decided to do locally when we looked at the evidence for that, and we had the availability of those resources. So certainly women with haemophilia over the age of 50 would fall into that. Women who have had joint bleeds, so those with severe von Willebrand's disease or some of the other rarer bleeding disorders, then again, absolutely by the age of 50, I would do a bone density scan. For other bleeding disorders without joint damage, I don't have a particular I don't know that we need to treat women with a bleeding disorder differently to the general population. So it's certainly easy in bleeding disorder clinic to measure vitamin D level, to talk about calcium, to talk about trying to ensure that everyone knows actually bone health is important. And, so as a woman of a certain age, actually I started going to the gym and doing weight training exercises a few years ago, because that having that impact and the weight training is really important for everyone, whether or not we have a bleeding disorder, to reduce bone density for women. So I would probably, for most women with a bleeding disorder, do general advice. But if there were any concerns, if there'd been a fracture, if there was another reason, then I would do the scan.
If I could just add as well,
Please.
that there is one thing that puts women at a much higher risk of osteoporosis. And as a man, I don't know if I'm even allowed to say the word menopause. Menopause by far is the single thing that increases women's risk of osteoporosis. And actually, many premenopausal women have higher bone density than men of the same age because they have so much estrogen coursing around, keeping those bones healthy. So I think most likely premenopausally, women can be treated the same as men with the equivalent bleeding disorder and risk factors, but it's very much after the menopause women's risk goes up, and I think we need to be very much looking for osteoporosis at that point.
So
Thank you so much.
I guess
Susie.
our next question was addressed.
Yeah. So thank you. You addressed the next question, and now I will go.
Oh, no, sorry, but can I add to that as well? Sorry, because I'd
Okay.
seen that question in the chat, so I think I already had the menopause in my head, but I guess broader than bone health. Because I guess the question is, what advice would you give to women who are starting menopause, especially those with severe symptoms?
Exactly.
So I would go to see your primary care practitioner, or the equivalent in whichever country you are in. So the haemophilia team will not be the best people to manage perimenopausal or menopausal symptoms, but we can certainly support, and we can support with any discussions. So there is now very good evidence for the benefits of HRT in perimenopausal and menopausal women, that your primary care practitioner will be able to talk to you about. I don't think we've ever been particularly worried about people with bleeding disorders and HRT, but certainly the other side of my job when I look after people with venous thromboses, the old HRT, which relied on estrogen tablets, is associated with a slightly increased risk of having a blood clot in your veins. But actually, certainly in the UK, that's no longer the most common type of HRT prescribed. Most people are on topical HRT as a gel or a patch, and that isn't associated with a significant increased risk of thrombosis. So in general, see your primary care practitioner, you should have all the standard support of perimenopause available. And I guess the only additional thing is if within that someone's getting heavy menstrual bleeding, then that should be coming to the bleeding disorder center for additional support. Many people have the Mirena coil, which has progesterone in and is very effective at reducing heavy menstrual bleeding. But strategies of supporting heavy menstrual bleeding can definitely be supported by the haemophilia team.
Thank you so much, Susie, for this explicit answer. So the next question says, I am very concerned about the side effects of drugs, as many of them have side effects. GPs and pharmacists have such limited knowledge of bleeding disorders and don't take bleeding seriously, especially when I have an ultra-rare platelet bleeding disorder.
Yeah, that's a great question, and it's something I face as a person with haemophilia, but it's something that somebody with an ultra rare disorder faces to such a greater extent, and it's a real challenge. I think the answer has to be shared decision making. So it shouldn't just be a medical professional telling you what tablets you have to take, but that has to be a conversation between you and your doctor. And I think we often do have to have, when it comes to something very, very rare, a hematologist in the mix to make those decisions as well. It's going to be a very individual conversation. All people are affected by medications differently, and so it's understanding what for you is giving you a greater benefit than a greater downside, and being aware that that might change over time as people get older, as they develop frailty. I would say that we do have a very good understanding of what medications cause bleeding and stop platelets working normally. So I think, we can quite safely prescribe most of the time, knowing that this is highly unlikely to affect that a platelet disorder, for example. But I think it has to be those conversations and those pieces of shared decision making. For me, that's how I would answer.
Yeah, no, I mean, I think that's perfect, and I don't have much to add. I think there aren't there are probably quite a lot, but many drugs and the majority of drugs don't affect blood clotting or platelets. So the vast majority are not going to interfere with your bleeding disorder, but definitely some do. So I suppose the most frequent discussions I have about this are either around pain relief, so with like non-steroidals such as ibuprofen, or there is, which as a general rule, we say avoid aspirin, avoid ibuprofen, but actually, if you need the occasional ibuprofen, then have that discussion with your own doctor. But if it's the occasional one, it will slightly increase your bleeding risk. But if it's what you need for your back spasms, on the balance of risks, it might be worth it. But do have that discussion with your individual hematologist. But also, for example, quite a few of the antidepressants, when you read the side effects, it is recognized that they can cause a mild platelet dysfunction. So I've definitely seen some people with bleeding disorders who have been anxious about then starting the antidepressant. And in general, for something like that, I think that discussion and the shared decision making that Will has alluded to is really important. And in general, I would give the reassurance that it's likely it will be fine. It will slightly increase the risk of bleeding, but for most people, the benefit of being on the antidepressant will be more than the risk of bleeding. If you take the antidepressant and it works, then great. If you take it and it doesn't work, you shouldn't be on it, and doctors should be trying something else. If you start taking it and you are noticing increased bleeding symptoms, then we can address that, potentially stop it, try something else. So some things are being comfortable to speak to your haemophilia team and just have often a brief conversation, but at least that conversation about that balance of risks and a bit of a trial.
Thank you, Susie. I have the last question in the chat, but then I have a bunch of questions, some from me and others from anonymous box that we have on the page that I have just shared in the chat. So a question from our chat here. I was told I have osteoporosis following a fall and breaking my wrist. I was put off drugs, but should I be reviewed? And as I'm getting very nervous about falling, I haven't been reviewed in 3 years.
Well, sure, I'm happy to jump in. I think that's really two questions, isn't it? It's one, when should osteoporosis treatment be reviewed? And two, how can I address my fear of falling? So I suppose firstly in regards to osteoporosis treatment, so we diagnose osteoporosis brittle bones on a scan called a DEXA scan, which is a type of X-ray scan. Once on the basis of that, we might commence vitamin D or calcium. Sometimes we commence stronger drugs, though, called bisphosphonates, and common ones are alendronic acid or risedronate, sometimes other medications, such as denosumab or teriparatide. Actually, we know that once people are starting on a bisphosphonate, so that would be the weekly alendronic acid or risedronate, often patients can take those quite safely for 5 years before needing to reassess. Sometimes after 5 years, we would consider stopping those medications for a period of time and considering are they necessary to continue. But I would reassure that if the medication is well tolerated, continuing on that even after 3 years is probably reasonable. But I would suggest potentially another couple of years. It's something that may need reviewed potentially. In regards to fear of falling, certainly once you've had a fall, you've had a fracture, there's a real psychological hit that comes with that. You think this is going to happen again. I'm terrified of that, and that's difficult. And I think that's where the MDT becomes so important. So setting realistic goals becomes important. So I actually often bring patients to see the physiotherapist in my unit, just so the physiotherapist can show them what they can do and show them that they can do it safely. And by setting realistic goals and gradually increasing those over time, it can be a great way to build up confidence. So if you've had a nasty fall, it's going to take time to get over that, but maybe you're going to start walking to the end of the street. Maybe you're going to start walking into town. Maybe you're going to eventually go back to hill walking that you've lost confidence to do. So it's really all about getting support around you from your healthcare team, setting realistic goals and building those up over time. Susie, I don't know what your experience is with people who've had falls and they're trying to regain their confidence.
Yeah, I think I would echo everything that you say. We are very reliant on our physiotherapist for supporting the recovery of that, and kind of both initially and then trying to do ongoing exercise classes to try and help instill the confidence of what to do. Yeah.
Just, I suppose, one final thing to say is that I can reassure you, a multifactorial falls intervention definitely reduces your risk of falls. So if you've been in, you've seen the physio, you're doing your strength and balance, you've got proper pain relief, you've stopped that dangerous medication, your falls risk is now lower. So you can take confidence from that.
Thank you both. So there was an article mentioned about frailty and frailty syndromes in persons with hemophilia that our speakers wrote. Of course, I read it. I have my notes. So here it's mentioned that, and something that William also said, that the current aging cohort of people with hemophilia did not have access to regular safe prophylaxis when they were young. So the question that I immediately had, how different then aging will be for the current youth? can we assume that it will be different? In what sense? It will be easier or the same? Any thoughts of that?
Yeah, well, I mean, time will tell, really. But yes, I would expect people to, in general, be aging with far less joint damage. So we see it kind of even now, kind of our patients aged 25 and less generally have perfect joints, whereas those who are older can have very significant arthropathy. And that's not just because of the age. Like there's a difference between pristine joints still at 25 and the older cohort who had, joint damage already kind of as teenagers. So as we are able to treat hemophilia more effectively, we should see less joint damage over time. So then the graphs that I showed you with our younger patients with severe and moderate hemophilia having significant arthropathy and high frailty, I would expect that to change. But for everyone with bleeding disorders, it doesn't cause the joint damage, and all those other comorbidities and managing those with hemophilia, that won't change. So there will always be a proportion of people with bleeding disorders, with frailty, that it's important for the hemophilia team to help support, recognize and support.
Thank you, Susie. I have a question from the anonymous box. How important is access to physiotherapists with experience of hemophilia for patients over 60 years old? I guess the answer is very much. But...
Yeah, very much. So I would go young. I mean, I know we're doing aging, but I think having access to a physio for anyone with a bleeding disorder is immensely important. It's not all about joint damage. Some patients are hypermobile, others have other issues. So I think physio is crucial. I think often there is not enough access to physio. No matter what center you're in countries, there will always be a variation. I know that locally, if some of our patients with bleeding disorders are in another hospital or seen by a physio who does not have expertise in bleeding disorders, they are very nervous and they kind of almost always refer back to us, and we have to do quite a lot of support. So I think having access to a physio is the key thing, but having access to a physio who is comfortable with bleeding disorders is definitely ideal.
Thank you. Short question. You said that data is missing even for hemophilia patients. Do you know if there is any research focusing on other bleeding disorders, at least on Willebrand? I'm not talking about extremely rare. I understand it's still a long way to go, or we don't know about anything.
So for frailty and frailty syndromes, I'm pretty confident that there is nothing. Okay. There are things that we can draw on from kind of, there are some studies around kind of people's mobility and independence and how many drugs they are taking. And there's definitely kind of data on people with von Willebrand's disease and other comorbidities such as heart disease risk and stuff. But there's the discussion about frailty and frailty syndromes is very new.
Okay, and the last question, thank you for staying still here with us. How we as patient organization and you as clinician talk about frailty to patients so we don't scare them, we don't have natural rejection, because I understand it's difficult to talk about all these things, and we have had already some discussions around aging with a bleeding disorder, and we have a lot to come in the coming months. So are there any psychological tips from you?
Well, I suppose I would say that I do think frailty is a bit of a loaded word. Patients don't like to be called frail. And I would say a couple of things to that. So often I would talk about frailty as a medical condition. So it's not something that you are, it's something that you have. I wouldn't, for example, call a cancer patient cancerous. You know, so I do like to talk about frailty in terms of you have frailty rather than you are frailty and you're defined by that. I often think as well, frailty is all about the health problems you've gained and the resilience you've lost. Another term that I think we should use more is intrinsic capacity. So talking about the capacities and the abilities that you still have. So you can still go up your stairs, you can still walk your dog, you can still drive your car. So I do think we as geriatricians need to re-angle to talk more about intrinsic capacity, to talk about the things that people still have rather than always focusing on the things that have been lost.
Thank you. I don't know, Susie, if you want to add something or.
No, I was just thinking it's a great question, and Will is the expert on this because like I'm still learning and our haemophilia team is still learning, and we definitely realized quite quickly after we started measuring frailty in clinic that people did not like the term frail, which was clearly down to both the term frail, but us not explaining well enough what we were doing, why we were doing it, kind of, and the implications. So I think there's a combination. I think partly us learning from all of Will's and gerontology's expertise that's already there, but partly starting to have these discussions as a community so that it's a more recognized term and the understanding why it's being done. And also you as patients saying, actually, this is how I would like to be told. This is, you know, how I would like to understand it. And then, you know, we can adapt together.
Thank you so much. I think together we can achieve that. Thank you, everyone.